Hello, 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 everyone. It's Dr. Tamar Beckford, and welcome to the Dr. Tamar Beckford Show. Today, we are delving into AI. That's right, artificial intelligence in healthcare, and especially for cardiovascular care. I have an expert here with us today, and I cannot wait to introduce her to you. All right. Her name is You'll find out in the end because it's wonderful doctor. She graduated from the University of Athens. That's right. She did her residency where I did my residency in Philadelphia at Thomas Jefferson University Hospital. Hello to all my Philly people. Hello to all my Thomas Jefferson people. Hello, hello. Then she did her cardiovascular fellowship at University of Alabama, Birmingham. She also did additional training at Harvard Medical School, cardiovascular imaging. She did multimodal cardiovascular training at Brigham and Women's Hospital in Boston. She is an expert in cardiovascular imaging with clinical niche in cardiology oncology. That's right. That's all about the cancer and heart. So we'll find out a little bit more about that. She is a rising leader in the AI space. She's very passionate about developing and implementing AI algorithms to optimize clinical workflows and ensure the delivery of high quality, equitable care to all patients' communities. She's been recognized several times and she has multiple awards, including in 2016. She was the Rising Star in Healthcare. She earned that award in Alabama. She also earned the Women in Cardiology Trainee Award for Excellence by the American Heart Association. Who am I talking about? If you haven't figured it out, I'm talking about Dr. Effie Andrikopoulou. Andrikopoulou. That's right.
Yes,
Andrikopoulou. There we go. Dr. Effie, how are you?
I'm doing very well, Tamara. You can call me Effie, please. We're colleagues. Uh, Tamara, I'm doing great. Thank you so much for having me, for such a generous invite. I've been following you on LinkedIn, and I'm a huge fan. And so when
Oh.
you reached out, at first I was thinking to myself, is this a scam? Is this really hard? So as soon as you reached out, I said yes right away.
Oh, thank you so much. And thanks for all that you're doing in healthcare, the innovation, all that's going on. There's so many people who when we think about AI, we get nervous, like, uh-oh, but you're going to really put us at ease and let us know all the wonderful things that are going on within that industry. But before we jump all into that, I want to find out about Effie. Little Effie, when did Effie decide I want to be a doctor? Tell me.
So first of all, I was born and raised in Athens, in Greece.
Mm-hmm.
And in Greece, I think much like the rest of Europe, even though I'm not 100% sure, I believe we don't have college after high school.
Yeah.
And so after high school, we enter straight into university schools.
Mm-hmm.
And the way I found my way into med school was a little unorthodox. I am not one of those um, individuals who always dreamt of being a doctor. Um, I was, but thinking about it now, I think
Mm-hmm.
I was always drawn to challenges, to
Ah.
personal challenges.
Mm-hmm.
And I saw that as a challenge because med school, especially at University of Athens in Greece, is the most prestigious,
Mm-hmm.
um, hardest to enter type of university school in Greece.
Mm-hmm.
And I saw it as a challenge whether I could do well enough to enter into that school.
Right.
And I was torn, which I think, again, reflecting on this now,
Mm-hmm.
it's kind of like explains why I'm drawn to AI, because um, the schools I had ranked was alternating med school in Athens, and then
Mm-hmm.
the second one was electrical engineering
Ah.
in Athens because I loved
Mm-hmm.
math. It made a lot of sense in my head.
Of
And
course.
yes, and thinking about it now, how my love for math and computers and machines,
Mhm.
with serving our communities, and like the humanitarian humanistic approach
Mhm.
to service, and marrying them together with medicine and AI now, it makes a lot of sense.
I
um,
love
so
it.
that's how I entered into med school. I'm
Mhm.
not one of those people who always dreamt of being a doctor,
So you didn't come out the
but
womb and said, "I'm going to be a doctor."
no. But I will say that
Uh-huh.
I do not regret it one bit.
Oh
I'm so
no.
glad I went into medicine. I was super young when I was called to make that selection, that choice. I
Mhm.
was 16 and a half,
Yeah.
barely 17 years old. And
Mhm.
so, as one might imagine, a lot of things might change.
Right.
Um, People, we're always entitled, and we have the right to change our mind about anything and everything in life at any
Mhm.
point, let alone when you're a teenager. And
Yes.
I'm very very grateful and relieved that that I ended up loving medicine, because I don't regret it one bit. I'm really glad I decided to have that as my first choice.
One of the things that I love about this is not just deciding early, because I'm from Jamaica, and a lot I understand, because the similar sentiment
Okay.
occurs where if you wanted to go into medical school, the University of the West Indies, you're making those decisions after high school, which is what we're
Yes,
basically
super
saying.
early.
So after high school, which is very early, but you had a love and a passion for math, computer science based things. And then you have this drive to say, I want to do something from a humanistic standpoint, which you would have had to have that, because both you can get from that school. The best school in the country. I want to go there. So you put forth all of that effort and the drive, and you were accepted into the medical part, right? But then lo and behold, who would have thought that many years later, there's going to be this portion that gets to use that other love that you have, right? And now
Yeah.
you merge. So there's no lacking, there's no feeling that I missed out.
Not at all. Yes,
You
not
know,
not at
it's
all. Not at all.
it's as if like you have now emerged into both of your passion and both of
Yeah.
your love at the same time, and
Yeah.
this is the moment for it, which is
Yes.
what
Yeah.
where we are now. So going back to the medical part, right? You had made the decision. Of course, AI was not out then, at least not to the public, but
No.
yes, it might have been worked upon. But when we're in medical school and you decide on where you want your journey to go, which specialty you want to go into, you decided on internal medicine. What made you make that decision?
Yeah. So that's also not a very straightforward path
Mhm,
and route. I was in Greece. I do not come from a family of physicians.
mhm,
My family, as a matter of fact, they're not university schooled. My parents didn't even make it through high school.
mhm,
And so they were very, very hardworking to raise me and my brother. Um, and while I was in med school in Athens, I halfway through, I
mhm.
realized that I don't know exactly why, but something inside of me was pushing me and telling me that I want to train abroad,
Right.
not in Greece.
Mhm,
And I wanted to live more. But at that point, I had never left my family's home because I was born and raised in Athens. I entered med school in Athens. I lived with my parents, and so
wow.
yeah. So
So
so here I am. At that point, I was 20 years old,
mhm,
and I start thinking to myself, I wanna leave. I wanna
mhm.
train abroad. How do I
Right.
do that? How do I prep for that?
Mhm,
And I remember seeking advice and mentorship and counseling from one of my university attendings slash professors.
mhm.
And I remember going to him with a lot of nerve
Of
and
course.
saying I wanna train abroad,
Hmm.
and I want to do it somewhere in Europe because at that point I was fluent in English,
Hmm.
but I also had a really really good foundation in French and German. So I was
Mm.
thinking maybe I go somewhere in Europe. And he turns to me and he says, "Effie, trust me, I really think you should try for getting your training in the US.
Mm.
It's the highest quality, it's the best training in the world." He had trained in the US. He had
Right.
trained the endocrine at Mayo in Rochester.
Right.
So me being 20 years old and the nerve, I turn to him and I go, "No, I'm not interested in the US. I want to go somewhere in Europe. Thank you." And I leave. Yeah. Who is this person? Like who
That's
is
the
this girl?
same bold person that says, I'm going to try to get into the best school
Yeah.
in the whole country.
Yeah.
That's that person.
So then I left and then I go back. But again, the nerve, like think about it now. I'm thinking to myself, what this man, like the amount of generosity that he had for me
Right.
must have been immense. So then a few months later, as we're getting close to the end of that year,
Hmm.
and there were 2 years left to be done with med school. So
Hmm.
I go back to the same professor asking him the exact same question. And he turns to me and he goes, "You already know the answer I'm going to give you. You're coming back here. You already know the answer. You should go to the US." So then I think to myself, okay, fine, I'll try, but I will give it my best try. And
Hmm.
so in my second to last year of med school, I was studying for med school, but also for the first step of USMLEs, which I
Hmm.
took and passed and did very, very, very well. And that started to make me think, okay, maybe I should try to go to the US.
Hmm.
And I applied to come to Hopkins as a visiting student in my final year of med school. And
Hmm.
I was very, very honored and privileged to get accepted and do my surgery and pediatrics rotation in my final year of med school at Hopkins.
Nice.
And I loved it. That was the first time, mind you, I ever left home,
Right.
was to go to Baltimore from Athens. and and I loved it. I loved it. Like from day one, I
Mm.
thought to myself, okay, this is where I need to train. And then, long story short, I've completed my rotations there. I graduated from Athens
Hmm.
because my rotations got acknowledged from Athens.
Wonderful.
And I spent the first year and a half ish doing research at Hopkins, and at the
Hmm.
same time getting my applications ready for residency. At the time,
Hmm.
I thought I was going to go into surgery to do cardiac surgery eventually,
Ah.
because
Mhm.
I was a huge fan of Grey's Anatomy and I loved Christina, and I was
I
like,
love how
I
we're
wanna be I wanna be
basing
this
our career
person.
choices. You know what?
Pretty much, pretty much, pretty much. But during my year of research,
Mhm.
that was one of the first life lessons.
Mm.
During that year of research in Baltimore, I realized that what we like as medical students, and if we have medical students in our audience and
Yes.
viewers, what we like as medical students is it can be, doesn't have to be, but it can be different from what we would want to do when we're 50 years old or 45 years old or
Mhm.
even younger, and we also want to have a family or want to do other things in our lives.
Correct.
And I realized that I wanted a different type of balance and lifestyle for me
Mhm.
that
Mhm.
would allow me to have other interests and other activities. And that's when I switched it, and instead of planning applying to surgery for cardiac surgery, I changed my application to apply to internal medicine, with the plan all along being to go into cardiology.
That was going to be my next question. Is were you thinking along that lines that said, okay, I still love
Yes.
everything from the cardiac standpoint.
Yeah.
I want to be able to practice this type of specialty. So when you went in, and for those who are probably sitting and wondering, like, what, why is internal medicine to cardiology? Just want to give them an idea that that's the path to a lot of the specialties. So a lot of your specialists, they start off internal medicine is one of the doctor's doctor. It's the grounds, it's a foundation, one of the foundations of medicine overall.
Yes.
So an internal medicine doctor has really mastered the foundation of the different specialties, the medical specialties, while the general surgeon does a lot of the surgical specialties, and then they enter into the specific specialist part. Right, for you, you did part one, which
Yes,
is cardiology.
which is called cardiology.
But cardiology is part one of the specialty. So
Yes.
now, as a cardiologist, you went even further. So tell them what it is that you did after doing the cardiology fellowship. So you did
Yes.
internal medicine residency, you did fellowship in cardiology, and then you went further. Tell us what you did.
Yes, and then the last part of my medical training was an even more specialized training, and we
Absolutely.
call that advanced fellowship is a
Mm-hmm.
term for that.
Mm-hmm.
And that was dedicated in cardiovascular imaging, in all different testing that we can do to image the heart and vessels. And that
Mm-hmm.
includes ultrasound imaging, which we call echocardiogram, the one that's specific for the heart,
Mm-hmm.
radionuclide imaging, and by that we're talking about nuclear types of stress tests, or
Mm-hmm.
PET imaging tests for the heart to
Mm-hmm.
detect either heart disease like blockages or inflammation,
Mm-hmm.
um, and cardiac magnetic imaging of the heart, cardiac MRIs, and coronary, excuse me, and computed tomography
Right.
scans of the heart, cardiac or coronary CT scans.
Right.
And I
Right.
did that for 2 years.
So this multiple years of training
Yes.
so far, so
Yes.
far. And
Yeah.
I'm not talking about in addition to the other things that you've done. We're just really just specifically talking about the training
It's
directed
medicine.
towards her love and her passion for cardiovascular research and to be able to help those with heart disease,
Yeah.
to be able to help with prevention management and coming up with plans to help even other specialists and other medical teams.
Exactly.
Alrighty, so now you're there doing that. And when did you see the incorporation of AI, artificial
AI.
intelligence, start to, because a lot of us, when we think AI, we're thinking Chat GPT. Like, okay, well, what does Chat GPT have to do with my imaging? Well,
Yes.
let people know what it is that artificial intelligence does within the healthcare system.
Yeah, that's a great question, and it's a loaded question. I'll try to summarize
Yes.
it,
Yes.
but feel free to ask me, and I can give more details. I'm happy
Yes,
because
but
I love
we're
that
going to
topic.
go a little deeper. After that, we're going to talk about it within cardiology. But
Perfect.
yes, yes, within
So,
the healthcare system, people are just kind of like, okay,
yes,
they have no idea where this is going.
yeah. Um, so within healthcare in general, and then we can narrow it down into cardiology, but within healthcare in general,
Mm-hmm,
um, AI didn't really start becoming a buzzword
mm-hmm.
until COVID hit us,
Yes.
because that was a little brutal and a little yeah a little brutal and
Yes.
abrupt push for all of healthcare community and all of
Mm-hmm,
our healthcare system in general,
mm-hmm.
to push us to become more agile, to push us to change. Basically,
Absolutely.
in general, whenever I think about AI in my head,
Mm-hmm.
I think about change.
Yes.
And anything that has to do with AI is nothing magical. It's not. It's nothing that just somehow magically appeared.
Mm-hmm.
It's been around for decades, since the 50s. Um, it's very, very widely adopted and embraced and used in all other types of industries, all other types of sectors, from banking, finances, retail, gaming, transportation, you name it. Everyone, every industry sector uses AI.
Mm-hmm.
Healthcare was the last frontier,
With a late
Um,
adapter.
Late adapter, and for good reasons.
Absolutely.
Our field is very high risk. Stakes are high.
Mhm.
We
Yeah.
cannot afford to try out new things just because.
Mhm.
When we try something out, it has to be vetted, screened, tested, validated multiple times, not just once,
Mhm.
extensively, and that's how it should be. That should not change.
Absolutely.
Um, but at the same time, COVID, even though it was, I mean, COVID was devastating.
Mhm.
Um, at the same time, it pushed us to reconsider how we're doing medicine. To put it
Mhm.
very, 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 very simply, how were we doing medicine? Was were we part of a patient-centric or a system slash physician clinician centric system?
Mm.
Sadly, we up until now we had been part of a system-centric
Mhm.
system, of a clinician-centric system, of a provider-centric system, and not of a patient-centric system.
Mhm.
What because of what COVID catalyzed, it wasn't the reason, but it was a catalyst. What COVID catalyzed was us reconsidering our approach to medicine and our culture within medicine and our mindset.
Mhm.
And it made us realize that it's time we started shifting our mindset into a patient centric one. How can we serve the patient where and when they want and how it works best for them?
Right.
So at the end of the day, that's what artificial intelligence is here to serve. It's not here to replace the doctors.
Mhm.
I do not think AI will replace doctors. It will replace tasks
Mm.
that doctors do,
Mhm.
and it should replace the repetitive tasks that should get automated. It should
Mhm.
replace tasks that can minimize human error. We're all humans. We all make we are making mistakes every single day.
Absolutely.
Um, but what AI can help us with is take the burden off of administrative, repetitive tasks,
Mhm.
um, of clinical modeling, help with decision making when that can be standardized, because there's a science and standardization, but there's also an art to medicine.
Yes.
Care should be personalized, and that's where the art portion of medicine comes in. Um, but we can leverage AI to help us regain our role as healers,
Mhm.
as as the people who are there to sit down with the patient and listen to them actively and have the
Mhm.
time to do that, not checking our watch and the clock and the time to
Mhm.
make sure that, oh my gosh, like I only have 15 or 20 minutes to see this person,
Mhm.
and then I cannot spend any more time with them because not because I have more clinical work to do, but because I have administrative, repetitive work to
Yes.
do.
Yes. I'm
Um,
glad that you've described, and I aptly describe, when I describe medicine, I describe it the same way, in that there's the science to it and then there's the art to it. And the art of medicine is that gestalt, it's that little notation, the inflection in the voice, the one statement that the patient just so happened to have made where they didn't even think it was important, but changes the entire dynamic
exactly.
of where you're going with the diagnosis,
Exactly.
based on clinical acumen. And it's
Exactly.
not only based on algorithms, but at the same time, there are many portions that are based on algorithms. But, as in medicine, we say when you hear hoofs, you think horses, not zebras. But with the clinical acumen, you can determine, wait a minute, there seems to be a zebra running amongst the horses.
Yes,
And that's
exactly. I
the
love that.
part that you
Yes.
said that, cannot be replaced directly with, because that's a big fear of those
Yeah.
in clinical medicine. Like, am I going to be replaced by artificial intelligence. And after interviewing a few doctors like yourself who have worked within the space directly, I'm hearing the same answer, which is reassuring.
Yes, yes.
Hmm.
I think it will change, and that's okay. It will change some of our
Hmm.
activities and parts
Yes.
of our role, and
Hmm.
that's totally fine. Um, like I said, I gave a talk recently on AI, and I said, would we give up our Amazon Prime accounts and start going back to the stores for every single thing that we needed? No, but we still go to the store. I mean, we still go to
Yes.
the stores.
Hmm.
Same thing with medicine. um, there's definitely a value in using AI
Hmm.
to make our role more proactive, not reactive,
Hmm.
to be promoters of health as opposed to fighters of disease.
Hmm.
So we can use AI to help us uncover insights that otherwise we wouldn't have been able to see from the data.
Right. Right.
We can use AI to make care more equitable.
Hmm.
There's a lot of caveats to that,
Yeah.
and I will be happy. I'm happy to talk about it more. But as long as we set ourselves up right and we set ourselves up for success,
Hmm.
we can leverage AI to make care more equitable and be able to reach patients how, how they would like to be reached.
Hmm.
Um, in addition to also delegating repetitive administrative non-clinical
Hmm.
tasks to AI, um, like coding, billing,
Hmm.
and the likes. And then that will free up so much of our times as clinicians to actually use that time to sit down with a patient and connect with a patient.
Right.
Um, because what I'm afraid might be happening right now is that even though the patient is talking to a doctor, it feels like they are talking to a machine. Even though we're humans, we crave
Hmm.
connection as humans.
Hmm.
Um, yeah.
One of the additional things that you have done is not just the AI in healthcare within itself, but also how you've been able to apply it to that sector, which you're just very passionate about, which is the cardiology. A lot of people are trying to figure out, like, how is one using artificial intelligence in cardiovascular imaging? um, is it that we no longer need our CT techs? Do we no longer need our echo techs? Are they, should they be worried? Thank you so much.
No,
We love you. Bye.
right.
We have
Yeah.
we
No,
have
no, no.
robota who's
No,
gonna be
yeah,
with
right.
us.
No, 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 no.
Okay.
No, we definitely need our techs.
Hmm.
For sure. We cannot live without our techs. They're an
Absolutely.
integral part to all of our labs.
Yes.
Um, and and techs that are highly skilled make all the difference.
Yes.
Those are the ones who enable us to provide with accurate interpretation of studies and then help the patients and the clinicians who order those studies. So we definitely need our techs.
Yes.
We're very grateful to our techs. Um, but having said that, there is a lot of we have been using AI, even
Mhm.
though we may not have realized that, and I'll explain how and where. And we're using it more and more.
Mhm.
So, is for anyone who knows anything about cardiac myocardial radionuclide imaging,
Mhm.
nuclear tests,
The nuclear
we,
stress test, that infamous, I got sent for a nuclear stress
exactly,
test.
exactly. So, the main interpretation platforms and softwares that we
Mhm.
use across the country and abroad,
Mhm.
those are all AI based, because what we did was we imaged a lot of people
Mhm.
and we created databases
Mhm.
that we are using now every day whenever we look at those tests and those pictures to
Mhm.
compare our patient's picture to the database that comprises of normal and abnormal pictures, and we
Mm-hmm.
compare them to see if our patient picture looks normal or abnormal.
Right.
Is the machine is the software making the diagnosis and making the final decision on what we will call normal or abnormal? Absolutely not. This
Mm,
is a decision that the reader makes, that the doctor makes when we look at those pictures, but we
right.
use that as an aid, as a
Wow.
guide.
Mm-hmm.
Or if we're not 100% sure, because life is not perfect, pictures are not always perfect,
Absolutely.
um, if we need a guide, then we click that button and we look at the results that the software provide us with,
Mm,
um, and then it's up to us to make the final decision if we agree or if we don't agree. I don't
right.
always agree, for
Right.
instance. um, so that's something that we have been using for decades, and that's
Mm.
AI. That's essentially AI.
What
um,
it sounds like is that you've been using a reference guide, you know? So when we think about even now, how we train to try to find normal, you need to be able to look at multiple images of normal in order to
yes,
look at an image and say, well, wait a minute, this is abnormal. Why? My
exactly.
eyes are trained to see the difference because I've looked at multiple images of normal. So the way that you've described it is this AI has been this guide and this reference that you can go back to say, wait, this looks abnormal. Let me see if it correlates. If AI is saying, oh no, this is normal or this is just an artifact, like, that's
Yeah,
some of the things that you can, and you can say no, based
exactly.
on my clinical acumen from seeing these truly abnormal ones, this is not an artifact. This is a truly abnormal read. So
Absolutely.
it's interesting. I've never thought about it that way, that you're using it as a guide, as a reference. It's almost like you're going back to your textbook, but now it's just
Yes.
an electronic version of it.
Yes, absolutely, absolutely. And that's just in nuclear tests. Then
Mm-hmm.
we already have AI that we're using for our cardiac MRIs,
Mm,
our coronary CT scans,
mm-hmm.
and in echocardiography. With echocardiography, we're using essentially AI whenever we do 3D
Right.
reconstructions,
Yes.
or automated 3D reconstructions, or automated strain assessment. If
Mm-hmm.
if I'm saying something and we need more explanation, I'm happy to provide. But
I'm here imagining this because I go over to, as a ER doc, I'm not seeing the cardiovascular ones directly,
yeah,
but I do go over to my radiology department when I have my patients coming in for these things like, okay, I'm
yeah,
worried about that stroke. I'm worried
yeah,
about that the aortic dissection, you know?
yes,
So, and there's a 3D image that our techs are able to, like you said, use the
exactly,
aid. So now it's clicking that when we're making, that aid of that 3D reconstruction, that's AI that's helping. For me, I'm just
exactly.
like, oh, the computer did it. But
And
now
that's very much it. Yes, the
yes,
computer did it means AI basically.
yes.
And we use it mostly right now in imaging to automate segmentation
Mm-hmm.
of chambers, vessels, valves. Um, and now we're increasingly using there's solutions that are now coming out
Mm-hmm.
to even detect disease. For
Right.
instance, in cardiology, with cardiac imaging, diastolic dysfunction and
Right.
diastolic heart failure
Mm-hmm.
is which accounts for 50% of all people who live with heart failure is
Correct.
diastolic. So it's not the most commonly thought of one when the heart muscle gets very, very weak,
Mm-hmm.
but it's the type where the heart muscle gets stiff.
Right.
And even though that accounts for 50% of all people with heart failure, our medication options and the options that we have to medically treat these patients are much more limited compared to the other half with
Mm-hmm.
weak heart muscles.
Mm-hmm.
And we're realizing that this it's urgent and it's imperative that we start to care for those patients in a much more effective way. The
Mm-hmm.
problem is we don't have the greatest way of even identifying and detecting
Hmm.
that disease. It's very elusive, it's very heterogeneous. It can be the result of lots of different types of underlying processes and pathologies that
Right.
can range from long-standing hypertension
Mhm.
to amyloid and anything in between.
Right.
And so AI, and one of the solutions that a year or so ago got FDA approved, is out there to is part of the of doing an echocardiogram.
Hmm.
The tech or the reader don't really have to do anything, and it uses an image to then stratify and assess the risk of that person having this subtype of heart failure.
Mm.
Which is great, because then it makes us wonder,
How many
is
of
this
these
an
are
opportunity?
missing?
How many are we missing, and do we need to redefine the
Mm.
disease?
Hmm.
Are we even defining the disease accurately? It goes back to what I was saying about using AI to help us uncover insights and
Right.
uncover blind spots and things that we wouldn't even have thought of, maybe,
Hmm.
because again, we're limited as humans.
Yes.
um so
Wow,
yeah,
this
and
is very interesting.
not to mention automating detection of blockages in heart
Hmm.
vessels of
Hmm.
coronary artery disease with coronary CT scans, and companies like HeartFlow and Clearly, that are out there now and are trying to automate detection and automate refined and sophisticated
Hmm.
characterization of cholesterol plaques of atherosclerosis that affects the coronaries. So it's not just an invasive coronary angiogram. It's not just the left heart cath, which is,
Right.
I like calling it the luminogram.
Hmm. Yeah, we're
Um,
shooting and looking at this, the dye going up, and
yeah,
the way I describe it to my patient, I'm like, it's like the traffic jam. Like, is the traffic flowing or is it completely stopped?
exactly, exactly. But with the coronary CT angiogram and with those advanced AI algorithms,
Hmm.
now we can characterize atherosclerosis and characterize the entire vessel,
Mm.
not just the lumen that we could see with just the left heart cath. So again, there's so much more insight that we can get from those tests. And again, begs the question, do we need to redefine what it is to have
Right.
coronary artery disease and atherosclerotic heart disease?
Right.
And yes,
This is
there's a lot of, and we're not even going into cardiac MRI, and it's
well, one of the
yeah,
things I do want to ask, because in addition to being an expert in the artificial intelligence, you actually like what we call niche down even more into cardio oncology.
oncology.
So, and this conversation could go on and on and on because I love it, but we will eventually have to end. But we will
Yes,
not end without us delving into this part.
yes,
How does cancer affect the heart on a general say? Is it like, how is it, and how does it affect the heart, and what about it that drew you to that niched down portion of your specialty?
yes. Um, the thing that I'll start by what drove me into
Mm-hmm.
cardio-oncology, and then I will explain, and then I will talk about
Yeah.
how the intersection of cancer and heart disease.
Yes.
Um, I quickly realized, while I was in Boston training in imaging for those 2 years, I realized that um, uh, I definitely wanted to be seeing patients, because I spent those 2 years as a radiologist. Essentially, I was every day I was in the imaging lab. I
Yeah.
was not seeing any patients. And first of all, that's when I realized that it's very, very important to me that I also see patients.
Right.
And I started thinking to myself, how can I apply my advanced imaging expertise
Mm-hmm.
in a subset of cardiology that that is growing, where
Right.
there's lots of unknowns and there's lots of room for growth, and with understanding more about it. Now, granted, we don't know a lot in any aspect of cardiology. We just talked about bread and butter, heart
Right.
disease and blockages, and how we still don't know. But um, that's what drew me into cardio-oncology. It's a relatively new but very, very rapidly expanding and evolving and growing field of cardiology. And the reason is, and now I'm going to start talking about the intersection of cancer and the heart.
Mm-hmm.
The reason why this is rapidly growing is because we're increasingly recognizing that there's a lot of intersections and overlap
Mm-hmm.
between the underlying process of cancer and heart disease,
Mm-hmm.
because at the very, very bottom of those two there's inflammation.
Ah.
So if there's one keyword that I would pick to summarize the similarities between cancer and heart disease, is
Mm-hmm.
inflammation
Mm.
underlying both.
Wow.
So now we're increasingly recognizing that cancer in and of itself is a risk factor for heart disease, development of new heart disease, and vice versa. People with heart disease are at higher risk of developing cancer. So that's one part. The second very, very important part, and what was the catalyst for the expansion of the field of cardio-oncology, is that we realized that uh, there's a lot of advancement in cancer treatments,
Mm-hmm.
chemotherapy, immunotherapy, cell-based therapies, radiation treatments, surgeries. So there's a lot of advancement in um, drugs and radiation treatments in cancer, and which is great because it means that people with cancer go on to survive their cancer, and they're
Absolutely.
cancer survivors and they live long. However, as this is happening, we also started realizing that people live longer, but
Mm-hmm.
they go on to start developing heart disease
Mm.
after their treatments, be that chemo, immuno, cell-based therapies, or radiation therapies. They are at higher risk of developing heart disease, and that could range from the most frequent one is heart failure, is weakness of the heart muscle,
Mm-hmm.
but they're also at higher risk of accelerated and faster progressing atherosclerosis and cholesterol plaques and blockages of the heart vessels.
Mm-hmm.
They're at higher risk for high blood pressure, that's hard to control. They're at higher risk for valve disease because after being exposed to radiation treatment,
Mm-hmm.
especially when the heart is in the field of radiation, there's a much higher risk of the heart valves getting thicker and calcified, and that
Mm.
can lead to them getting obstructed and narrow and not opening all the way or
Right.
starting to leak a lot. Um, in addition to pericardial issues and inflammation of the heart muscle too, with one of the most one of the latest types of immunotherapy treatments, the immune checkpoint inhibitors,
Mm-hmm.
they they are showing tremendous results in helping people with cancer live much, much longer and
Mm-hmm.
survive their cancer. However, they do come with a risk, even though not too high. But
Mm-hmm.
again, we're understanding more and more, so things change every day in cardio-oncology. But they do come with a risk of inflammation of the heart muscle that
Mm.
at sometimes can be very, very bad to the point where it can lead to detrimental, life-threatening events.
Mm-hmm.
Um, so that's where the two overlap and intersect. Is in real life practice, what we see is the side effects of treatments of
Right.
cancer that
Right.
affect the heart. And those people are um, they they need a specialist because of their cancer treatments. First of all, we always have to weigh the
Mm-hmm.
pros and cons. We never want to withhold life-saving cancer treatment.
Correct.
We always try our very, very best to keep them on life-saving treatments, but at the same time we have to make sure that we preserve the heart,
Mm-hmm.
and we don't save them from one disease only to have them suffer from a different disease after they're done treating their cancer. um
This is very, very, it's deep, it's interesting, and it's a sector that, as you said, it's not explored that much. It's new in the explorative portion, but it's very interesting because as you're learning about the use of AI, now I can see how important it is to help with the not just the risk stratification as should I give this or shouldn't I, but how can we now develop even medications to be able to directly hit the
Exactly.
cancer but not affect the heart, or
Exactly.
even using the radiation like as a, for I can imagine that in radiation oncology using the beams, being able to use artificial intelligence to be more precise where we're directing it more of a pinpoint and not being able to affect the organ that's around it, which, if depending on the area that the cancer is, could be the heart. And
Exactly.
reducing the risk of, like you're saying, the cardiovascular disease. um I never thought to pinpoint that the inflammation in cardiovascular disease and inflammation in um the in cancer. I was thinking about like those are it's the, like you said, it's the V, it's the zenith of this whole cascade that eventually happens.
Yes.
So getting to the root, but using AI to gather more data versus being afraid of it and not using it, where you're ended up guessing and you're surmising. But when you have the
Exactly.
data, then you can use data driven information and make data driven decisions
Exactly.
based on the art of medicine and the science of medicine.
And
Very
even exactly, yes, and even to use AI to help us design clinical trials
mm-hmm.
and make sure that that we make them diverse in
Right.
terms of participation of people in it.
Mm-hmm.
I will tell you, Tamara, we're in 2024. We
Mm-hmm.
just had our American College of Cardiology conference in April in Atlanta. And in
Mm-hmm.
one of the studies, one of the clinical trials, we were celebrating the fact that it had included 80% women, which never happens. And
Wow.
we were celebrating that in 2024. So, I mean, yes, it's great, and we should celebrate that.
Oh
Yes.
yes, but it also
But at the same
shows
time,
the
yes,
fact that we had to celebrate it,
yes,
how far we're coming and how much farther we need to go.
yeah, exactly,
Because in order for you to make effective treatments, we
exactly.
need to have data from everyone so that the treatment can be effective to that population.
Exactly. And I also want to say, and
Mhm.
everyone does not mean both genders. It
Right.
means every socioeconomic
That's
group.
true, because there are multiple factors that affect, yeah, how someone lives. It's, even when we're talking about inflammation, a lot of it starts with diet. Diet starts with availability of food, availability of
Air
healthy food,
pollution in
air
the environment
pollution.
that we
That's
live in,
true.
our
Where
neighborhood, our zip code.
yes, so many factors that lead to that start, which is that inflammation. Very, very,
Absolutely,
very powerful.
absolutely. And not all women are the same. Not all
Yeah,
women are the same.
yeah, yeah,
Just like not all men are the same. We're not all the
absolutely.
same. So it's not just about gender diversity, gender-based diversity and gender-based equity and inclusion in clinical trials that AI can help with, but
Mm-hmm.
also with fair and diverse representation from all socioeconomic backgrounds.
Mm-hmm.
Um, to make sure that exactly what you said, what we develop meets the needs of everyone,
Right.
not just of the select few who were able to make it to the
Mm-hmm.
trial office,
Mm-hmm.
to the clinic office to participate in that
In the
trial.
trial. Wonderful. Now you're really bringing light to the importance of AI in healthcare as a hope for improvement
Yeah,
versus the fear that is usually brought in when one thinks of using artificial intelligence. There's so much hope and light that I'm getting from this part. But I do have to ask, because you've done a lot. A lot. And you're constantly thinking and you're constantly improving and you're constantly trying to find ways to improve on your patient population and how to improve on healthcare overall. But one does a lot. Sometimes they get burned out. Have you ever experienced burnout?
Um, yes, I
Hmm.
have.
What did it look
Uh,
like?
I did experience burnout, and I'm thinking about it because I'm also very mindful of it, and I
Hmm.
don't want to experience. I don't want to experience burnout, so I will tell you when I experienced it, and I will also tell you more recently what I'm trying to do, because like you said, there's a fine line when when you have the energy and the excitement and the passion and you want to do things, but at
Hmm.
the same time it's very important that we are mindful and we pace ourselves,
Absolutely.
and we balance our energies.
Hmm.
So I did experience burnout in the last part of my training,
Hmm.
because of everything that was very, very new. I was in a very, very new environment. I was studying for my cardiology boards and starting a very new fellowship, which,
Hmm.
like I said, I was functioning as a radiologist essentially, which was very new. I was not.
Hmm.
I was 6 years into my training. I had always trained as an internist,
Right.
seeing people, and yes, but not being a radiologist. And
Hmm.
so there were a lot of um, challenges that
Hmm.
I'm now grateful for, because as a result, I grew
Right.
professionally. I grew
Mhm.
my skills, because now I can look at vascular CTs and MRAs and no problem. But
Right.
back then, and with everything else that was on my plate, it was tough.
Yes.
Um, so it was tough. Plus, I also think, even like we were talking about, like our environments. I love Boston. I love Boston. But again, it was very new for me, and I was
Hmm.
moving from the south, from Birmingham, from Alabama, where it was always warm and sunny, and I was in Boston, and I wasn't seeing the sun because I would go into work super early before the
Hmm.
sun was up. I would leave work and it was dark. So, and I was, like I said, as a radiologist.
And so you're sitting in the dark.
Yes.
Oh.
So that first year, it was 2 years. That first
Hmm.
year was challenging, but it allowed me to grow.
Hmm.
Um, I don't um I don't want to paint like a pretty picture though. Like, I'm not saying that we should embrace burnout because we're gonna grow. That's not
No,
what I'm
it's
trying to
a part
say.
of it. And you know what we can discuss or is to really talk about what were some of the things that you noticed
Yes.
within yourself
Yeah.
when and you can look back now and say like, wow, that
That was not myself. Yeah. So in a nutshell, I
Mhm,
was not myself that I was not myself that year.
mhm,
Um, I noticed that I wasn't smiling as much. I
mm,
wasn't I wasn't bubbly like my normal self is to be bubbly and smiley and, oh hi, how
mhm.
are you? I
Yes.
wasn't like that. Um, I my sleep quality was affected. I
Mhm,
wasn't getting a good night's sleep, which
mhm.
means it perpetuates the problem, because then you're not rested during the day, because
Yes,
now your mood is affected even more.
correct.
Um, I didn't, so I experienced things like that. It wasn't like I shut down and I couldn't work,
Right, right.
but it was like I just, like, my personality was changing. I was
Mhm.
not the same person. My energy levels were not the same. My personality was not the same. My sleep was affected. Um, yeah, that changed
So what
that
is it
year.
that you'd say that you do now whenever
Yes,
something like that creeps in? Because a lot of times it's one of those, at least now where we are, it's a hindsight is
yeah,
2020. And what is it that when you notice this, now I do that in
this,
order to
yeah.
prevent burnout?
So I will tell you, one of the things that I do now, and
Mhm.
that's not negotiable.
Mhm.
I always, almost every day, very, very few exceptions, I will go to the gym. That's 1 hour for myself.
Mhm.
No, non-negotiable.
Mhm.
I am going to the gym. I usually do it after work. I'm not an early riser. I wish I were and get it out of the way.
Mhm.
But I will do that for myself. So that's 1 hour for myself, no negotiable.
Mhm.
And that's honestly, that's when I feel the most accomplished is after I'm done with my workout. Like it doesn't matter what else I've done during the day,
Uh-huh.
but yes. And then the other thing that I do is I it's more of, so now again, now I'm in a new position,
Mhm.
relatively new, and I'm the director of the Echo Lab at Harborview,
Mhm.
University of Washington in Seattle, which is new for me. I've never had an administrative leadership role,
Right.
but I'm still seeing patients. I'm still like full-time clinical work.
Mhm.
So now the past few weeks, I'm realizing that the work is starting to build up.
Mhm.
um, and I reached out to my administrator colleagues to tell them that, hey, we need to look at my time.
Mhm.
So let's work together to make sure that time management works for me.
Right.
So yeah, so I'm trying to be proactive by reaching out to my employer and say,
Mhm.
hey, let's work together to make sure that my time is more balanced. Um,
Mhm.
and they have been very responsive, and they agreed with me right away.
Right.
And that's actually a great test for any employee, reaching out to
Mhm.
your employee, because we know when we work hard, we know, and it shows. Also,
Yes,
it showed
absolutely.
objectively. It showed on my yeah, on my productivity metrics. It
Mhm.
showed.
Mhm.
Um, so that's a great test for to our employers as well, to see how they will respond.
Mhm.
Because if they don't acknowledge that when it's objective, and we're telling them to, and objectively they can see that, then
Mhm.
that's a test to see if, like, the quality of the employer as well.
Love it. Love it. So when you noticed for your burnout within yourself, your personality changed. You weren't your bubbly self. So you started to lose some of what makes Effie Effie,
Yeah,
right? And you also noticed that your sleep quality went down, which started a vicious cycle
yeah,
of mood change, which now you're not getting enough rest. So you're tired during the day, and it's just starting that cycle going down. In addition to that, you now realize that, okay, as my role changes, sometimes burnout can happen during transitions, right? Where you're given the best of yourself,
yes,
and you're wanting to give more and more in order to really show how much you want to provide it's usually in
yeah,
a given role. So you, in order to mitigate that, you have now said, okay, I'm going to put in a few parameters to help with that so that I can be more productive. And it's showing in my productivity. It's showing, in the way, in the care that I'm able to provide. Because how great can the care be when you can't be yourself? You've
yeah,
lost some of you, and your mood is changing, your sleep quality is changing. Then that clinical acumen that we talk about will start to go down.
yes,
So it's that's so important. Now we're gonna talk about our fun question of the day before we wrap up this wonderful. This is like super interesting
yes,
conversation. Obviously, I can go on and on. Alrighty. So if you weren't a doctor or an engineer
yes.
or starting an AI company
Okay,
or dabbling into anything artificial intelligence,
okay.
what would you be?
Okay, so I guess that takes out like a math researcher too. Would that, it would fall
Yeah.
under engineering?
Yeah, so
Okay.
you love math, you love engineering,
Okay.
you
So
love
I've got that
AI,
aside.
you
That
love
aside. Okay.
medicine, so you can't do any of those. This is
Okay.
my fun
Okay.
question.
I will tell you. I would want to be one of those um art historians, how you
Oh,
study history of the art, and then you can work at a museum
mm-hmm.
as like to evaluate the exhibits, to be a curator, or to
Yes.
that's what I would want to do.
You are my first. I asked this question to like almost like over 250 people because I'm making this utopia in my mind where
Okay.
all our physicians in this wonderful world, and
Yes.
you are going to be my art curator who's putting
Yes.
together this wonderful exhibit of all things art.
Cause like during COVID, I would
Hmm.
log on to YouTube and watch videos explaining the story and the meaning behind
Yes,
pieces of art and
yes,
creators too. So they would
yes,
start talking about a certain painter or yeah,
yeah.
and those professionals sound like they know so much, and I was so impressed hearing them and watching them explain a painting. And
Yeah,
I was thinking to myself, wow, you can see all of that stuff in that
from
painting.
that
That's
painting.
amazing. That's amazing. That's amazing. You're super smart. So yeah, that's what I would want to be. And very calm, like very calming, very meditative,
Yeah,
very yeah, that's what I would want to be.
I love it. Alrighty, so there's so many people who have been watching this wonderful, wonderful conversation, Effie, about your journey into medicine, your journey into cardiology, your journey into cardio-oncology, imaging, all of these wonderful things, where you see AI going, how you're using artificial intelligence to help in not just being able to identify things, but going even further for preventative care, how we can see that in preventative care in general medicine, in the specialties such as in oncology, when patients can survive their cancer and also be able to live a thriving life afterward because you're able to preserve the cardiac or heart function. Someone out there is like, I need her to talk to my company. How can I bring her on? I'd love to have her mind in my company. Tell them, where can they find you?
You can find me, the easiest way to connect with me on LinkedIn.
Mm-hmm.
And yes, that would be the easiest way. I check LinkedIn every day. I'm very, very active. I post almost every day, or I will reshare something every day.
Mm-hmm.
So I would love to connect with all of our industry colleagues.
Yes.
um, we cannot do this. If there's one thing that AI is here to teach us, is that we cannot, as clinicians or health systems, we cannot do it on our own. We
Right.
have to collaborate, and we have to embrace diversity, cognitive diversity in our
Mm-hmm.
collaborations, and collaborate with tech, collaborate with AI companies,
Mm-hmm.
collaborate with our insurance companies too, to try
Mm-hmm.
to understand how to best serve our communities and our patients.
Mm-hmm.
And I would love to connect with anyone in industry.
Love it. Well, there you go. Those of you out there in the industry, this is definitely a beautiful mind. You have This conversation has blown my mind. It's opened up
Thank you
my
so much.
mind to artificial intelligence in healthcare in a different way. I've interviewed other clinicians and we've talked about it, but this one was just a little bit different. And it's great to be able to have angles that intersect in order to really provide the care that we want for our patients and the different patient population that we serve. So thank you so much, Dr. Effie, for jumping on
Thank
with
you.
me today. Now I know some people are on and they're like, oh, okay, Dr. Beckford, I'm glad that you came on at a different time today, but you know what, did not get all of the stream because I was busy. But I said, have no fear. This wonderful conversation is available on our Your Caring Docs website. That's URCARINGDOCS.com. Select podcast, and you'll see Dr. Effie's beautiful face. Download the episode, send it to 10 of your friends. Those who are thinking about artificial intelligence, their fear of artificial intelligence, those who are in the industry and they're like, oh, you know what? I'd love to be able to connect with someone who is really forward thinking, such as this wonderful doctor. Now, if you are out there and you are looking for a dynamic speaker to speak on stress management and burnout prevention at your next event, I am she. Send me an email at drbeckford@yourcaringdocs.com, and I would love to connect with you and be there to give a dynamic speak at your next presentation or event. If you're also looking for stress management and burnout training for your company, connect with me also. I'd love to be able to do that for you. Alrighty, Dr. Effie, is there any last words that you have for those who are out there watching?
Yes, I want to say that I had a great time. You're an amazing host. I really, really loved our conversation. I wish it would go longer.
Yes, me
Um,
too.
and no, this is amazing. You're doing great work. Please continue doing it because I know that I'm definitely enjoying all of your podcast episodes, and I'm sure everyone else out there is too. Thank you so much for all you do.
Thank you. And thank you for all you do. Thank you for taking the time to share this wonderful, wonderful information with our audience out there. For those of you guys who took the time out to listen to this wonderful episode, I thank you also. I'm Dr. Tamara Beckford with the Dr. Tamara Beckford Show, and I will see you guys next time. Bye bye.
Bye.